This is part of a kind of a dialectic process where we took what we thought were some of the key themes from our interviews and conversations with policy experts like those at the roundtable today, including them, and from the evidence reviewed, and put forth what we thought might be some best practice recommendations for CPAC to share with the world. We have not had formal votes on these in the past, not like we're going to try to vote on each of them. What we want to try to do is to capture, I mean, obviously if everybody just rises up and says that's ridiculous, we don't want to say anything about that, or we want to say something completely different, we may have to obviously take it offline. But what I'm hoping is that we can talk about ways that we in general agree with this as a group, as CPAC I should say at least, and whether we want to not wordsmith, but suggest ways that it could be improved or added to or otherwise amended. And there may even be some key recommendations that are not even on this list at all. So we have how many total? About 10? Nine. About 9. And so let's try to go through them and see what specific thoughts we have. And I obviously invite the policy experts to comment as well. It's not just CPAC. So the first one is on credentialing. Is certification and credentialing, is that considered the same thing in the field? When we say those two words, do they mean the same thing to you?
No.
I think certification, I think there is a difference.
My understanding, and I'm not a lawyer, is that certification is one type of credentialing, that there's also licensing and registration, and I think there's one other, but they have different levels of legal impact. That's correct? So certification is one type of credentialing.
In your policy fields, do you guys spend your time talking to each other about certification or credentialing?
We're doing certification.
Certification. All right, so we're going to change this to certification. That's what I thought. So number one will be certification. I'll just read it. Certification should not be required for practice as a community health worker, but credentialing. Certification is important for increasing recognition of the workforce and to demonstrate standards to payers in order to promote a sustainable model for CHW reimbursement. Yes?
Can we add something that I heard from the panelists and also in the materials, that it not become, that it be accessible, maybe with no fee, that it be something, there's a recognition that these are people who are from underserved communities who are going to have to try and get this credential, that it be accessible and meaningful, but that we don't professionalize them out of it.
Actually, our first bullet states it in the negative about having an unintended consequence. I think if we frame that as a positive about the ways that, well, anyway, we will try to capture that idea because I agree. I think that was an important part of the conversation.
See, here's the language. I'm not so, if I'm trying to, if I were Rob getting this, what does this mean? It says it shouldn't be required, but it is important. So what is it?
It's going to end up.
We need to, all right, we need to blow this up. What we mean is that it shouldn't, it's that kind of, do we need to wait now before we do anything until people are certified? I guess what we want to say is that it shouldn't halt the use of CHWs in the short term, but in the longer term it will be a benefit for the workforce to have certification.
Could that be? Can I add a
clarifying? Absolutely, this is what this is about.
Because I think there's also a sequential nature to this where people should be able to enter the field and work without certification, but that certification provides a career path, a career lattice after that point. So there's two time periods we're talking about. One is we shouldn't stop the field from progressing, waiting for certification standards. And secondly, there should be an entry point without certification, and then certification becomes a career path. Is that fair?
Well, we're going to try to capture the multiple time flows here because I think there will be a time in a couple of years, perhaps, when we would all say, well, there are robust certification programs, and we really shouldn't be hiring people who aren't certified anymore. But we'll try to capture the idea that now we wouldn't want to stop. Jeff?
Well, and to what's the end point here? Are you asking for a payer to get involved in certification and credentialing, or because those mean a whole different...
Right. No, we have multiple audiences for these best practices recommendations. What's a practice anyway? This one would be more for state and other policymakers who are working, and for people who are working to try to create a certification process to encourage support of that, I guess, in the longer term. Gail?
I just wanted to echo what Jean said, is what we are doing in Massachusetts is exactly that they're, first of all, it's not mandatory, and that people enter the field and then they become certified after that, and we're actually talking about, and this comes from community health workers themselves, that they will need a certain amount of work experience in order to be actually eligible to apply for certification, because they need to sort of have that hands-on experience to be certified.
Josh?
I think this relates a lot to what we were talking about this morning and the problems of interpreting the literature. And you and Steve, you just described the dilemma of Medicaid at CMS about how are they going to measure the results of their investments. So I think that in addition to maybe assuring quality in a CHW program clinically or public health-wise, it would also advance, I think, the state of analysis of programs to have a certification requirement at some point.
I'm trying to think if we have written in here somewhere the evaluation. Yes, number 9 is evaluation, so we will get there. That's one of the best practice recommendations. So, but I see how this would feed into that, perhaps, the idea. Other comments, Julie?
So a recommendation that we had coming out of our non-traditional health worker report was to have a grandfathering clause, which kind of addresses the work experience and then certification path. So in our rules, we have provisional certification for individuals who've gone through some training but haven't met the standards that we just set. And then we also have a grandfathering clause that allows workers who have been in the workforce for some time to certify in with very minimal training added. That's to decrease, so people can continue working without having to take time out to do the training that they might already have those competencies in. And then in our rulemaking process, we really engaged the community and took in all the comments from the public, including the workers themselves. So I think if a state were to set up a certification process, they really need to engage the community health workers who are already existing to make sure that as they're developing the rules and standards, they're not creating barriers that are unnecessary.
That's very helpful. Thank you. Felix?
Looking at it from another way, wouldn't certification be a way of sort of directing government, state governments into recognizing the profession?
It will help.
Unless I'm wrong, I'm nodding my head, yeah. I think
that's
that's
certainly happening in our state.
But it's not happening in other states. Other states haven't quite gotten there yet, or are we all heading there anyway?
Well, Gail, why don't you comment, because you've been in conversations with a lot of people.
Yeah, no, it is happening in other states. I mean, there are other states that actually have established this before us, but I think it is all moving in that direction. The way my phone is ringing off the hook, I think there's a real interest in this. When you say certification, it makes people listen up, like you say. I think there's definitely a move in that direction.
What's interesting is I think historically certification in part began because they were trying to get fee-for-service payment, and there was no way to even imagine a fee-for-service payment to an individual providing a service unless they were somehow certified. Now that we're more in the global payment world, certification doesn't serve that same entry criteria. It's not as necessary in a sense for payment structures, but I think it's still viewed as very important by the field to advance the quality of the workforce and their own position within the overall medical community. Is that fair?
I would agree with that.
Okay.
So why wouldn't we say that certification is best practice?
Well, I see what you mean. Well, we do say, well, the way it's worded now, it's supposed to say that certification is important. Certification is important for increasing recognition of the workforce. I think we could word that more strongly if CPAC wished. We could say that states should seek a process towards certifying community health workers.
I guess what I'm objecting to is the first part of the sentence.
Oh, but that gets to the idea again, which we have to fix the wording, but it was trying to acknowledge that right now where there are no, for instance, in New England, there's not a single certification program. So we wanted to admit that perhaps that doesn't mean that they shouldn't be hired now, but that we want to move towards a certification program.
What about something like it's important to identify the skill set and characteristics of people? That's getting into more wordsmithing, but I think that's what we mean by credentialing or by certifying, that we identify the skill set and personal characteristics of the people licensed or ideal.
All right. So I think we have the general thrust of what we want to say, and I don't want to spend time wordsmithing because that won't allow us time to talk about the other
Except
recommendations.
I would object to saying that certification is a required best practice. I think and training, I would say training is an essential, but certification is a step.
Which is basically what I was about to say. And looking back at my colleagues back there, my community health worker friends back there who came, I think had seemed to indicate they may have some very significant concerns about requiring certification. I mean, we're jumping the gun in that certification programs don't exist at this point. We don't know what will develop. But at the same time, we have to be very careful about closing out communities of workers who may not have that opportunity, at least in the short term, and maybe in a little bit of a longer term. I think that the training is much more important than the certification. And I must say, I like the idea of considering a certification, just like a teacher gets certified, let's say their 6-year certificate and a master's degree gets added qualifications and gets recognized, such as board certification for doctors used to be, it's not anymore, but it used to be, considered a special qualification that is a recognition route. And I think that would be more appropriate in this venue.
And in Massachusetts, the certification is voluntary, and that's really on purpose. We took many, many, many years to move forward with certification in order to do it carefully and thoughtfully and have it be led and shaped by community health workers so that they're defining their own practice, and other states just may not be there. So I would also be cautious about really strong language requiring certification.
Okay.
I also want to clarify, in Oregon, it's also not mandatory. People can choose to become certified. It is mandatory right now for anyone who wants to enter the Medicaid system. So if they want to be hired by CCO, it's mandatory because that's the agreement with CMS. But if you want to be a community health worker, you can do that without certification.
All right. So we'll try and have our cake and eat it too on this one. Now, I just want to point out we have 30 minutes left and we have 8 more of these. So we are going, unless we have some that are just slam dunks, we're going to spend, I'll cut it off after about 3 minutes on each of these, and we'll try to take it back and then we'll feed it back to you. Recruitment, recruitment. Oh, good, it's right up there. Community health workers, okay, you're going to argue with this one, must have the respect of the community. What we really wanted to do was to provide a few ideal approaches to recruitment. So the bullets talk about, getting the right people who have that community. We want to continue to describe that ideal of community health workers, that they come from the community, et cetera. We talk about ways that they can be found. We've heard some other ideas about approaching associations or local community organizations to try to find community health workers. If people have specific thoughts about other things we should add to this section to help flesh out the idea of recruitment.
Well, will the final paper have
the bullets?
Yes. An explanation? Okay, so that
yes.
statement
This is just so we could get it up on the slide. Oh, no, this was just to get it up on the slide. What will be in the paper is, well, this is the paper has the full paper has them, and you've got the bullets in your binder there. All right, I'm going to move ahead then, assuming that there's not too much to say. Good. We need some more of those. Training. A training curriculum should focus on the development of core competencies and skills that translate across disease areas or conditions. What's not a first sentence here right now is that all CHWs should receive training. I heard to a certain extent that was a feeling that broadly that they should receive training, and that there are curricula that we can help through our report hopefully identify some of the best practices and help people find them. The bullets, again, you guys can look at the bullets. I'm not going to try to read them out loud for everybody. But they go into a little bit more detail around the generalist versus specialist roles. We did not feel that we should say that one was better than the other. They're obviously complementary. Some CHWs will fill both.
I do have an addition.
Yes.
And it's foreshadowing one of the future bullets, and that is that they have training and working with other, in team-based settings.
Training in work, so specific training curricula to teach them how to work with, as part of the
With
team?
other,
All right.
with other members of
Yes.
healthcare and teams.
I
How-
think someone,
however you want to
Heidi,
say
I
it.
think you said that very specifically, that that's a component of training that you do that I think would be a best practice, training to work with teams. Yes, Si?
So how does this relate to one? So is the certification going to be based on these generalist qualifications, or?
Can someone just briefly describe, do you have certification set up to basically mirror the core competencies taught as part of a good training program?
That's that's what we're doing in Massachusetts, that there's, but the law actually calls for tiers of it calls for tiers of certification, but we haven't gotten that far yet. The core training, the entry-level certification is based on the core competencies that are being articulated.
Right. And what we have is a minimum 80-hour core curriculum training, and as a state, we're approving training programs to deliver all those topics, and then they verify that an applicant has completed it successfully, and then we certify that individual.
I think where the difference would come is, for instance, if you have a CHW who's been working in the field for 40 years and could demonstrate core competencies that would get them certified, but then wouldn't necessitate that they also go through 80 hours of training. Right.
Can we also talk about, there are a lot of patients who have more than one condition, and they talk about needing a care manager to handle other care managers. So I liked this, that there's a core competencies and that you would have training across all the disease areas so that we could start, and when I hear tiers, I hear levels of things, and then everybody's going to want to be a specialist because they're going to get paid more, and then people are going to be back to having to coordinate their diabetes and cardiovascular and all of that. If there's the core, I love the core competencies idea, and that you may be paid on a grant to deal with, maternal and child health, but if mom has diabetes, you can help her.
Yeah.
I don't know how to put that into words.
We will.
Okay.
But
Can
the
I
idea.
also add, in addition to the curriculum, I think the delivery of training and how it's delivered, in what format and in what locations is also important. It should be community-driven and community-based, or have that collaboration, so you're not recruiting from, you are recruiting from the right populations to serve these roles.
All right. We'll have to work a little bit more on that, because currently a lot of the training is within the program or the delivery system that hires it, so we don't want to tell them that they can't do the training.
Right.
It's got to be training in the community itself, but somehow we'll try to capture that. Let me move to matching, because this is a tricky area. I'm not sure whether we want to or need to have a best practice here, but it comes up over and over again, and it's kind of linked to some of the tension within the field about how general or specific many things should be. So the wording is that this same idea of having the respect of the community by demonstrating an understanding of the patient's entire cultural and socioeconomic environment. I'm not happy with that. It doesn't really mean anything at all. So what this real issue is in the bullets for CPAC members who are looking at it. The experts have argued to us that CHWs really should continue, as is the norm in the literature, to be matched specifically with patients according to shared culture or life experience with the community. That's at some tension with this idea of professionalizing them to be able to do community health worker work with different communities or different conditions. So,
yeah, shared culture I'm a little uncomfortable with, because I would think, there has to be some compatibility. Mention something about compatibility, but maybe a Hispanic woman would rather speak to another woman than a Hispanic man. I don't know.
So my reaction was, I actually like the unbolded sentence more than the bolded part before. And I accept that the unbolded isn't quite there yet, but I think that's closer than actually saying matching. I don't like that word at all.
yeah. Well, matching, let me just point out that was part of the evidence base. Matching is what has been shown to work. It is the evidence history of this field is based on the whole concept of matching. So that's why there's a tension around just throwing matching out, because it was the raison d'etre of this whole enterprise, and it is the basis for virtually every evidence-based program in the country.
Although matching was varied, it could have been on gender, on age, as well as cultural competency.
Yeah, is that the word that's, yeah, okay, we don't have to say cultural matching.
Right.
Maybe that's the wrong way to
But
do
that's,
it.
that wasn't my comment.
Oh, go ahead, sorry. It's helpful.
I usurped myself.
It's helpful, go ahead.
But I would be interested to hear if these elements are already embedded in the training, sort of developing that, cultural competency and being able to, is that already addressed in the training, which is addressed in the different standards?
Right, it's definitely addressed in the training, and the matching word, I guess it must be out there, but it's sort of I haven't really heard the concept before. And we talk about community health workers being hired because of their shared experience and knowledge with the communities that they're serving, but not specific matching.
Yeah, I think where this comes up is, can you hire a college student who grew up in Stamford, Connecticut, to be a community health worker in Dorchester, Massachusetts? And I don't have a particularly good answer to that, but I think that's what it comes, what? Because a lot of institutions, I can speak to one of my institutions who said, we're really not comfortable hiring people from the community who don't have a lot of education work experience. But if we paired them with a college student, we would hire them. And so the issue is what stance do we want to take? Do we want to say that these need to be people who at least represent the community, or are we willing to say anyone who demonstrates ability to get down with the peeps and be in the field can be a CHW,
Oh, we've got people who just are dying to talk over here. We'll interview you after the meeting. I apologize. I apologize. Tony.
If we look outside of healthcare, there's actually a long-standing and pretty highly regarded precedent for a matching kind of role if you really, if you want to be effective. And that's the ag agent role in the agricultural world. And Everett Rogers wrote sort of a seminal book on the dissemination of innovation, and how you actually make change happen in a community is to hire somebody from that community and match some of those cultures to that community. And much of the way high tech is disseminated now was based on that original work. And so it's in the literature.
All right.
Everett Rogers.
This is a tough one. Here's what I'm going to at least suggest. We may need to revisit the use of the word matching. We may be able to convey that concept in a word, because we want to use the language that the community of community health workers are familiar with and that they would use with policymakers and others. My own feeling is that based on the evidence and from our interviews with a broad variety of people around the country, is that this concept of both, in some ways, either drawing community health workers from that community or having some link that is deeper in some way. Culture is not the right single word, but some link so that they have that connection to the patient group or community to whom they are going to, with whom they're going to be working. I think we want to say that that will remain a best practice, in my view, based on the evidence and from what we've heard from a variety of stakeholders. So let me see if we can redraft some of this language and hit that target, and we'll see what CPAC thinks going forward. Somebody was nodding their head over there. Thank you. I hope. All right. All right. That's right. That's right. Oh, definitions. Maybe we'll get back there too. All right. Number 5. Are we up to interaction with patients? Okay. Again, we asked people in our interviews a lot about, so what do they do with the patients? What's a best practice? Because there's a lot of concern that you just send them in there and it's like a black box. They just sit down and chat, or what? So Heidi gave us actually a lot of insight into the specific training and even ways that she has taught her or trained her staff to record the level of intensity of the engagement with the patient on very specific criteria. There are some best practices out there that we will be able to make reference to. So what we tried to say was that patient interaction should include significant extended face time with patients and often families, We put individual visits in the home or clinic. Maybe we should put when appropriate or when, it's somehow, not sure. It's not always necessary, but it's often a core part. And active engagement with patients to plan for future care. Is that okay? Oh, good. All right.
I think you had, I have to say something. I think you did a great job capturing this. This was terrific.
Oh, thank you. You can stay. Number 6. Are we up to 6? Yes.
No. My hat with the matching things.
Do I need to go back?
For Heidi. How is that done? Does a manager like yourself decide, this person goes with that person, or is the community health worker involved in that decision, and like the team decides, this would be a good, maybe my hat with it. How does it work?
Yeah, it's and I would leave it up to the hiring organization, the management in the particular. So, for instance, if you're working on a domestic violence initiative, most of the time you're going to want your CHW to be female, and you're going to want them to have the same. So, it varies. Whereas when we've worked with, Haitians with HIV, they do not want a Haitian person because of the stigma associated, but they want a white person who speaks Creole. So you never know. So you can't make a prescription. I think the thing is you've got to figure out, and oftentimes we ask the patient to decide these are your options. We have someone who looks like this, we have someone with this, with that, and they decide. Or it's someone who goes in who says this person has, ridiculous borderline personality disorder. Annette is great at setting limits. She's the best match. So, you really have to do it one by one by one.
Okay. So number 6, we're doing okay with our 3 minutes so far. We probably need more for this one, but we'll still spend 3 minutes. Program funding. We had a hard time framing, in a sense, an action statement here because it depends in some ways. But obviously we wanted to state that there needs to be further work in collaboration between payers and providers to help develop more sustainable funding models. Most people would say yes, and then the details start to get in the way. So, for instance, we heard from Lisa, a potential best practice I could imagine would be CHWs should be included as a core expectation of the provision of high-quality primary care services or something like that, and then we figure out the funding later. I don't think we can probably go that far as a CPAC. We haven't gotten to that level, but what we would expect to do in the report is to lay out several possible approaches to a sustainable model. Not that there will be one, but that there might be several possible approaches. I would suggest that CPAC in our report and what we've heard from experts is all pointing towards the fact that CHWs are going to find a more sustainable funding model within a globally budgeted approach to healthcare. That spending a lot of time trying to get fee-for-service set up for CHWs is probably time not well spent. Is that okay with people?
How about encouraging them to fund it out of their case management budget, their existing case management budget?
So the question is going to be, should there be additional funds made available to pay for the value that CHWs bring to health? Or should the expectation, or should it be that take what you're currently getting and figure out how to carve it in to what we're paying you already? So we're not going to make a claim to one side or the other. Right. We could say as a group that we feel like it should be budget neutral. No further resources, therefore make CHW programs fit within the existing budgets of healthcare between providers and payers.
I'd like to see some language about transitional funding strategies.
Transitional funding strategies. It's interesting.
I also worry about mandating anything for anybody. There's going to be resistance from some communities and from some people are going to come to this sooner than others in care teams. And I think if you require it, you may move them away from whatever it is you're trying to, if it's a CCO or it's a patient-centered medical home program.
I think what we'll try to do is try to highlight a couple of existing approaches to paying for it as potential approaches, again, and not weigh in on this one of these 2 or 3 ways is the best.
And the only thing I would add to is to look at what we're paying for home-based services. in terms of is that value add? If you talk about PCAs or home health aides, all these other fields that we just pay for, huge costs, but don't have the same level of training, certification, quality improvement, and only to say that if you just take the duals and the disabled population, a huge amount of money we're pouring into PCA, where we aren't holding them to the same level of rigor in terms of outcome. Is there a way that, some of this CHW, training could be applied to people we're already paying for to improve the standard of care being provided? So I think there are other types of workers that we're paying for that we could transform without additional cost.
So what I'm hearing, if I could generalize it, is a call for creativity in looking at existing budgets that would identify the relative value of community health workers along with other kind of health workers in home services, that kind of thing. Is that fair? Other thoughts on this point? Okay, because people will look at this one a lot, this funding recommendation. One that I think will probably be fun to talk about because it'll be quick is care team integration. Right? One of the most valuable things I think I and our team learned from our conversations with stakeholders was this reverse idea of training. The idea that, oh yeah, well we can train our folks up to the hilt. The biggest problem is that we stick them in with a primary care team and they have no idea how to use this strange beast called a community health worker. They're out in the field and the community health worker calls in and no one answers their call and it's just a disaster. So what we try to call for is a clear approach towards integrating CHWs into the clinical care team. And we know how hard that can be to do, but I think it'll be a really important part of our report. People have specific ideas for things we should add.
Make it number one.
Make it number one. Gail?
No, I would recommend adding language about how community health workers are a two-way bridge and actually convey information back to the providers about the patients in the community, because sometimes that gets lost in the mix.
Okay.
Could you clarify the
Sure.
Interventionist term as it
that's the wrong
applies to
term.
not merely navigators?
Thank you for catching that. What that means is that they have some ability to control or operate the appointment system largely. So what we heard were stories of if they're out in the field and they see a patient and that patient needs an appointment that day, bad stories are they call in and they have to get into the same queue as everybody else and they don't have any, the community health worker doesn't have any way to manipulate the system to in a sense, play a role. Whereas other systems are set up that they have, in a sense, power to get a same-day appointment for that patient if they feel it's necessary. So interventionist is actually a terrible word because it recalls for doctors a lot of other things. But
I think I used that
Did
term.
you use it?
Yeah.
Well, the problem is it makes us think of people with sick needles.
I mean, I think that one of the things that I was saying is an interventionist, and I'm coming from an MD, is that the CHW can participate in the creation of a care plan that's contextualized to the patient, participate in the actual implementation of the care plan, as opposed to, here's a care plan and the doctor just needs you to get the patient there so they can do the care plan. So the CHW is saying integrating the team to actually participate in the creation of a care plan based on their knowledge of that person within their whole context.
Which sounds great, but also additional to the super navigator function.
Correct.
Right. And this may be where there's a tiny bit of tension with the medical liability issue, because insofar as they start to participate in medical planning and management, then it's might raise some concerns from medical legal perspective liability.
Well, yeah.
But I think we need to get rid of the word interventionist, or at least do a better job of defining it here.
Yes, and just a quick point, I don't know if the intent was really to focus on the clinical care team and those providing clinical care within a medical model, but given the sort of social model elements of the role of the workers, is it more an interdisciplinary or a healthcare team rather than just the clinical care team? Maybe the intent was to integrate the workers into those that are working clinically, or is the idea about this practice recommendation that they should be a member of the interdisciplinary team?
Oh, I like that. Yeah, in a sense, yes. we talk about integrating them in with the head honchos. What we want to say is that they become part of what is, in a sense, a new entity, which is a healthcare team as opposed to a medical team. I like that. Is that okay with people if we use that language? Okay. Believe it or not, we're going to skip participation incentives. You know why? I actually think we were just hung up on this one because we saw the evidence and then we heard from people and we decided just to throw it out there. I don't think this needs to be a best practice because ultimately we're going to find that participation incentives were largely used for the study purposes and it's not even going to be a big issue. So just you can almost forget about that one. So let's talk about evaluation. And here I'd like to actually ask you to expand this for us because we talk here about, well, we want to hear from you how best to frame a best practice around evaluating community health workers themselves, the work that they do as individuals, and as a new form of healthcare delivery. What further research should be done? What's the best way to do that research? This is a relatively large topic, but
one little modest wordsmithing might be to have programs should continue to evaluate rather than to seek. I mean, actually be more proactive in doing it, and then effectiveness on patient satisfaction, patient education. You know, but put something about patient satisfaction.
Get the triple.
Yeah.
I guess it's funny. We usually try to shy away from that because all too often satisfaction is the only thing that's measured, and then it becomes kind of useless in some rooms. But I think it's fine to include it along with health outcomes.
I would like to see patient-reported health outcomes in addition to other.
If we put patient-centered, because some of the times it's not obviously just patient-reported, but we could certainly in the detail indicate that the increased use of patient-reported outcomes would be helpful.
That would be great.
Sorry, Cy and then Mitchell.
So at lunch there was a lot of conversation about we didn't like to be limited to dollar equation with value, and so we've got patient health outcomes, and I just think that part of our uncomfortableness was that we knew there was value here beyond the cost effectiveness, so we were going to ask it to like be value effectiveness or something, but I think we just need to expand.
Well, what if we say that it would be helpful if research tried to capture the benefits and the costs beyond the medical system? Is that a fair? Because I think it's hard to do, but I think as a best practice, it would be wonderful to try to have
full
research
employment
that
for
does
researchers. I think it's perfect.
Let me let Jeff in, and then I'm sorry.
Yeah, not to that level of granularity, but what we look at when we have these types of programs on the payer side is member engagement, meaning if you stay engaged with a community health worker, sort of like when we design plans and you get a reduction in your premium if you know your numbers, if you complete a tobacco cessation course. So member engagement and avoidance of gaps in care. Those are things that are tangible, and I think that shows that there's positivity in the interaction and the person is still engaged. That's the thing that we struggle with the most.
All right, thank you. Mitchell.
So I think some of the value that we were mentioning can be quantified, and I put it as economic value. So time off of work, those types of measures to show that benefit because, again, going back to the population health discussion, it's the total cost that we're really trying to impact. And if we don't start suggesting to measure those things, we'll never get there.
Good point. Good job. Good job. All right, I'm going to stand up and go back to the podium. Don't go anywhere. All right. My main job is actually just to stand up in a place where you can all see me, people in the audience and the CPAC and our panel members. And thank you all for your participation. Our panel members have put in their time. Julie flew through hell to get here. They've helped us, the ICER team, behind the scenes because we obviously had to come up to speed in this area. And I'd just like to say that I hope you have shared with me the feeling that we bring people from across New England to meet like this. These people have spent a lot of time reviewing the report that we created. They've been very thoughtful about it. The comments that we've received already from them and from members of the public has been astounding. This is by far the meeting that's been attended by the most people on the outside. And I have to say that it's the first time we've done a topic other than a specific test or treatment area And I'm quite proud that CPAC has taken this on. I'm proud that we've engaged with the public. I hope that we've expressed our respect for the community of community health workers. We could have had you at the center of the table and you're on the outside, but I hope that's okay for today. Because this is the beginning of a dialogue, and we will turn out a final report and we'll have a lot further input. But my main role again is to thank you for your participation, look forward to the final report, and then we as a staff actually work with stakeholders going forward. We don't kind of put a bookend on it and then move forward. We anticipate working with Medicare, with payers, with provider groups and patient groups, and would love to see the evidence that we've discussed and some of the policy recommendations taken forward. So thank you to CPAC members, thank you to the audience. And our future, just in case you want to take a peek, do we have future topics on the slide? The announcement, so just one. Oh, sorry, Lisa, go ahead. Yes. Actually, do you mind coming to a microphone so we can get it on the tape? But then you're keeping people, you're keeping people.
Sorry. One thing that strikes me that was kind of touched on, maybe even more from different states than New England states, is the need to link to public health departments, to state public health departments. And, given our comments earlier about population health measures and who really takes care of that and has an eye out towards that and a vision for it, I just think somewhere, and I don't quite know if it was in 1, 2, or 3 or something different, should be said about the need to link community health worker initiatives to
public health
programs in states.
All right, I think that would be useful. So our next meeting will be in December of this year. We don't know exactly which state it will be in, but before that we'll have a final report and then what we call our action guide, which is a very condensed version with hopefully positive action-oriented statements for patients, for providers, and for payers. And my last slide, our backup slide. So with that, again, I'd just like to thank you all, and I hope you have safe travels.
Well, no, I wasn't there last week, so I didn't go through that. So you were financial secretary?